Hello, good evening. My name is Catherine Harley. I'm the CEO of Nurses Specialized in Wound Ostomy Continence Canada, and we are very pleased to be bringing you an educational webinar this evening that focuses on the lower extremity before it's too late, the importance of early intervention of vascular assessment. With us this evening, we have two guest speakers, and I'll be introducing them in just a moment. But before we get started, I wanted to draw your attention to the question and answer box at the bottom of your screen. And if you could put any questions or comments that you have in the Q&A box as we're going through the presentation, we'll have a moderated question and answer session at the very end. And so it gives me great pleasure to introduce our main guest speaker and our second guest who will be participating in the question and answer. Our guest speaker is Dr. Fady Elias, and he's a vascular surgeon and assistant professor at McMaster University in Hamilton, Ontario. He's a world-leading vascular surgeon and assistant professor who has joined One Vascular as a partner with Dr. Ted Rapanos. He completed his MD and vascular surgery residency at McMaster University. He completed his Master's of Science in Clinical Epidemiology at Harvard T.H. Chan School of Public Health in 2018. In addition, he has completed his Advanced Endovascular and Open Aortic Fellowship in 2018 at Paris University in France. He's the assistant professor for the Division of Vascular Surgery at McMaster University in Hamilton and practices in all aspects of vascular surgery, including medical, surgical, and endovascular management of arterial and venous disorders. He has numerous publications in groundbreaking research and a specialization and also went to the Royal College of Physicians and Surgeons Specialty Committee for Vascular Surgery and the Canadian Society of Vascular Surgery National Research Committee. Second guest this evening is Dr. Ted Rapanos, who is also a renowned vascular surgeon in Canada, based in Hamilton, Ontario. He's the Associate Professor and Academic Program Director in Vascular Surgery at McMaster University in Hamilton. And in addition to being the Academic Program Director for Vascular Surgery at McMaster, he offers patient-specific experience in endovascular aortic surgery, endovenous laser ablation, as well as a unique perspective in the treatment of infrainguinal disease. Further, Dr. Rapanos is one of the only few vascular surgeons nationwide to complete certification as a registered vascular technologist, affording him the ability to offer patients a comprehensive approach to vascular care. Dr. Rapanos built his clinics with an innovative flair and the latest in scientific advanced technologies. His unique approach to streamlined comprehensive care, from diagnostic testing to consultation and treatment, has increased productivity and communication with primary care physicians. I would now like to turn things over to Dr. Elias.
Thank you, Kathy, for the great introduction. And thank you, everybody, for joining us this evening and on your recordings later. So today we're going to be discussing vascular surgical assessments, vascular surgical health, and lower limb care and preservation. So what do vascular surgeons like Ted and myself do? So we assess all blood vessels, so arteries, veins, and the lymph systems outside the head and outside the heart. So the conditions that we treat are peripheral vascular disease, and that'll be a huge focus of our discussion tonight. Aneurysmal disease, so arteries that get enlarged and are at risk of rupture. Carotid disease, so having narrowing and stenosis in the arteries to the brain that cause strokes. Dissections, fistulas, so for dialysis care, and then we have trauma care. So what's the One Vascular approach, and why are we having this discussion tonight? So the current practice for reaching vascular surgeons is you'll get a referral from your primary care physician, your family care physician, and they generally send it to a general diagnostic center, and they generally have a very long wait list, so 8-12 weeks to get an artery ultrasound. And after that, once they get the referral, they see the patient back and they say, oh, they have a positive result. They'll refer it to a vascular surgeon in the hospital, which can take months and months and months. And some places have, a year wait list to see a vascular surgeon. And by the time they end up seeing them, their lower limb ulcer is much worse. They're at risk of limb loss and amputation. And these serious complications can develop where it's at risk of losing their limb or losing their life. So what's the one vascular approach? So once you kind of are referred to one of our centers, the patient's seen by a vascular specialist within 1 week. We set up the diagnostic testing. So that's usually an artery ultrasound, and we'll kind of discuss that further. And that's really right in the clinic at the point of care. We then set up a consultation with one of our vascular specialists where we describe, what's going on with the results as well as the treatment options. And all these full reports are sent to the referring physicians, all their care providers, and we set up a care plan. So we're not just seeing them kind of a one and done. These are lifelong patients for us, and we're setting up care plans for them. We also provide educational programs to understand, the signs of their vascular disease, when they should come back, being able to assess themselves for, if they develop any ulcers, to present to us for further assessment. Further to that, we provide patient education around their treatment and long-term solutions. So again, we're looking to provide preventative care for these patients. We obviously treat, if they have acute ulcers or acute wounds, but we want to make sure that we provide preventative long-term care for these patients. And finally, we work with the Community Healthcare Coalition. So that's ourselves as One Vascular, the cardiology group, KMH, and the diabetic group, LMC. So we provide comprehensive cardiac, vascular, and diabetic care for this high-risk population. So really kind of the goals of tonight, we're going to be talking about primarily peripheral arterial disease as well as venous disease, and assessing lower extremity wounds and lower extremity care. So peripheral arterial disease, to start with that, it is a spectrum of disease. So kind of like cardiac disease has patients that come in with an acute heart attack and acute STEMI. There's also people that have angina and have ongoing chest pain. Peripheral arterial disease has the same type of concept. There are patients that have claudication, and what that means is pain when they walk, and that's typically in the muscles, and that's at different levels depending on what level of blockage there is in the artery. And the symptoms of this are pretty classic in terms of pain in the muscle when they walk, and it happens at very reproducible distances. So every time they walk, half a block, they feel pain in the muscle. And then this pain resolves when they rest. So these are signs that these patients have peripheral arterial disease, and they do need our peripheral arterial assessments, such as an ultrasound, to rule out any narrowings or any blockages in their arteries and provide appropriate treatment. Then there's patients that have acute limb ischemia. So they were normal one day and not normal the next. So they're walking, they're moving, they had no issues, and then all of a sudden they develop pain when they're not moving, numbness and tingling in their feet, cold, and they have no pulses. And these are patients that typically were on blood thinners, and they were either held, weren't taking it, or developed new atrial fibrillation. And they threw clot to their legs, and they developed significant changes in their legs. And this is more of an acute emergency. These are the patients that should be sent emergently to the emergency room for assessment, and they need revascularization quite quickly, within hours, to save their legs. The biggest proportion of patients that we will talk about tonight and that are of concern, and it's within our group's discussion tonight, is critical limb ischemia. So what critical limb ischemia is: patients that have a lower leg ulceration or gangrene, or they have rest pain for a prolonged period of time, generally more than 2 weeks. So it's any one of these symptoms. The challenge with critical limb ischemia is a lot of patients that have the same risk factors for critical limb ischemia. So any atherosclerotic risk factors, blood pressure, cholesterol, diabetes, heart disease, smoking, also have significant lower leg neuropathy. So because of their diabetes, their renal failure, their atherosclerotic risk factors, they have significant neuropathy. And the neuropathy can cause either them to not feel things, and so they can't recognize having ulceration, gangrene, or rest pain, or also having significant ongoing pain because of the neuropathy. The important part to diagnose critical limb ischemia is understanding how much blood flow they're getting to the legs. And we'll talk about how to do that through ankle brachial pressures and ultrasound. So patients that have an ulceration or a wound, and they have peripheral arterial disease, and we'll talk about how to diagnose that shortly, have critical limb ischemia. And it's very important to diagnose critical limb ischemia, as these patients need urgent attention by our vascular surgeon. They need surgery to provide additional blood flow to their legs to save their legs. And they also need to be able to be assessed overall, because if you have blockages of blood flow in the legs, you can have blockages of blood flow in the heart leading to a heart attack, in the carotid arteries leading to a stroke. And so we're looking beyond just the ulcer on the leg, but we're looking as a patient as a whole to provide, saving their legs, preventing heart attacks, and preventing strokes. So this is something that we're trying to, you may be familiar with, and we're trying to differentiate in terms of if you have a patient that has a lower extremity wound or ulcer, what type of ulcer it really is. And so there's different features that represent the different categories. The challenge with these patients is many of these patients can have multiple components. So they can have a venous ulcer, an arterial component, and a neuropathic component. And so it's difficult to differentiate between each one of these. And often they have multiple components of them. Venous ulcers are typically, at the level of the medial malleoli. They typically have a more of a wet appearance. They typically have a lot more swelling. Arterial ulcers over the toe joints, under the heel, over the malleoli. Similarly, they can happen on the shin as well. And they have this red appearance, so that's more of that rubor, or that's what causes, that's in keeping with the pain that they have all the time. Last component is the neuropathic. So these are ones that have, more of a punched out appearance. Your significant diabetics that have significant neuropathy. And these are the ones that are over the joints, and they're secondary to kind of a pressure area where they develop these punched out ulcers. And we'll go over each one of these today, but to keep in mind, they're often having multiple components of it, and they overlap. So what are the causes of ulcerations? So the one that we're really focusing on today is the arterial component, because I think this gets underlooked and underappreciated significantly when we're assessing the wounds. So when we're assessing the arterial component, there's a macrovascular, or the large vessels. So the ones that have a name. So the aorta, the iliac, the femoral, popliteal. Then you have microvascular, so the really small blood vessels that are microscopic. And these are often patients with diabetes, renal failure, that lead to these types of microvascular compromise. Once again, often patients have both components, large vessel and small vessel compromise. A massive component of ulcerations as well is a venous ulceration. So these can be divided into patients that have obstructive. So they've had previous DVTs and they have problems with draining the leg in terms of outflow, as well as insufficiency or having valvular problems. So they have pooling of bloods in their legs. Like we said, the other components of having neuropathic neuropathic ulcers, having punched out appearances, having dependent ulcers in those areas, and pressure ulcers. And finally, the infectious component. So that can overlie all of these types of ulcerations. So the important note here is arterial component is a huge component of ulcerations. We have to try to differentiate and understand the source of it. It's important to, to treat the wound itself. And, that's a huge focus, especially with our groups. But we also have to try to identify the source of the wounds in order to prevent future wounds and treat the wounds as appropriate. So who's at risk for peripheral arterial disease? It's a huge patient population. The risk factors are what we typically talk about: high blood pressure, cholesterol, smoking, diabetes. There's often a genetic component. And if you think about it, if they have a history of coronary artery disease, previous heart attacks and strokes, and they have disease in their coronary arteries and their carotid arteries, they're at high risk of having blockages in their lower extremity vessels. And that's the same vice versa. So if they have blockages in the lower extremities, they will likely have blockages in their heart and in their carotid arteries, putting patients at risk of stroke. So what's important of how to assess for arterial assessment? So we talk about ankle brachial indices. So what that is comparing the blood pressure in the arm, comparing to the blood pressure to what's at the level of the ankle. And so you make it's an easy division. You do ankle pressure over the arm pressure, and you get a number. The normal number is 0.9 to 1. However, if your number is higher than that, that doesn't mean you're superhuman and have great blood flow. That means the blood pressure cuff can't compress the artery, which means your artery is very calcified. And that's often because of diabetes and renal failure. If you have an ABI of 0.5 to 0.8, you have moderate disease, and less than 0.5 is severe. And that is often indicative of patients that are at risk of critical limb ischemia or at risk of limb loss. So it's important to understand patients that have, peripheral arterial disease that don't even have symptoms, that don't have wounds, because patients that have peripheral arterial disease, which is the yellow column, have a very high rate of mortality. So this is comparing it to other cancers and other significant conditions such as stroke and coronary artery disease. So patients that have peripheral arterial disease and don't even have symptoms, don't have pain when they walk, and don't have ulcerations, have a 5-year mortality rate of 30%, because if they have disease in their blood vessels in their legs, they can have disease again in their heart and in their arteries to their brain, and are at risk of strokes. So patients that are having difficulty walking, so claudication symptoms, it's important to identify these patients because they're at risk of limb loss. And so these are the patients that we can target early in a prevention perspective, to get them on the right medications, to prevent them from smoking, to get them moving, to prevent future limb loss and future MIs and strokes, or heart attacks and strokes. These are in terms of patients with critical limb ischemia, so at risk of tissue loss. Again, it's important to have this discussion that they are also at very high risk of passing away. So this is a very vulnerable patient population, as you well know. So if you have tissue loss, rest pain, these patients have a 3-year mortality rate of 60%, which is, astonishingly high, and higher than most cancer diagnosis. So how do we treat these patients medically? There's a lot of great vascular and cardiology guidelines to treat these patients, but they need to be on an antiplatelet, so aspirin, a lipid-lowering medication, antihypertensive. They need to make sure that their diabetic control is maintained, as well as to make sure that they're not smoking, and finally keeping active and walking on a regular basis. So the guidelines are very clear. There's large randomized trials to support aspirin on a daily basis, as well as rivaroxaban for patients with peripheral arterial disease, to help both their legs and prevent future heart attacks and strokes. Similarly, patients that have a peripheral arterial disease need to be on lipid-lowering medication, and they are at the highest risk for future events. So we need to target these very closely. And as a review, similar antihypertensive medications and glycemic control. So how does imaging play a role in this? So if you are suspecting a patient with peripheral arterial disease, so you can't feel their pulses, they have a lower extremity wound, they're at high risk for peripheral arterial disease. So like we said, they have the risk factors for it. They should be sent for an arterial assessment, and that's an ultrasound. And so this is what you'll typically get out of an ultrasound result on the left side. So we have dedicated registered vascular technologists that are scanning vascular patients on a regular basis and have very detailed scanning protocols. And so they can give us very detailed images and an idea of what's going on from a blood flow perspective. And as you can see in this patient, you can see that their blood flow on the right, they have a blockage of the superficial femoral and the popliteal artery on the right side. And you can see the numbers down here. Their ankle brachial index is 0.5, so it's a moderate disease. And we also have an idea of how much blood flow there is at the level of the toe. So we've done a CT scan on this patient as well, and you can see the matching disease here. So often we're taking patients straight from the ultrasound to the operating room to do an angioplasty and stent, or to do a bypass without the need of a CT. So it also provides expedient care for these patients, reduces the chance of having issues with contrast and kidney issues. It also helps us watch these patients afterwards to make sure that they don't have repeat narrowings and requiring repeat intervention. Pardon me. So what kind of interventions can we provide? So there's both open surgical bypass and endovascular options, so angioplasty and stenting. And so you can see these are angiograms that we can perform to be able to open up blood vessels and provide less invasive methods. Pardon me. Similarly, even in our high-risk population group, patients that have blockages in their superficial femoral artery can get an angioplasty, pardon me, which is a same-day home procedure. They're in and out of the hospital on the same day. They are done under local anesthetic, so they're lower risk procedures. They don't require hospital stay or admission. They go home quickly, and they can get quick and rapid access to care, as well as a less invasive care in order to help their blood flow. So we have patients that had traditionally been turned down for surgical bypass because they're at higher risk, which definitely makes sense, but can definitely have an endovascular procedure in order to assist with their blood flow. And patients into their 80s and 90s, into their higher risk, that have ulcerations and at risk of limb loss, that we can provide less invasive procedures in order to assist with blood flow. So this is my kind of quick and easy workflow for assessing an ulcer that you have a concern that's arterial and how to manage it. There are many different types of wound care devices and dressings, but this is kind of my easy go-to assessment of an arterial ulcer. And what I start with majority of patients. Obviously, there are the complex and more challenging wounds that there's a lot of different options that we can upgrade to. So this is my quick go-to. So you definitely have to assess the arterial perfusion for these patients. And the best way to do that is, if they don't have palpable pulses, they need an artery ultrasound, like we discussed. You have to rule out an infection. So that's a clinical diagnosis, see if there's any discharge, and if there's any signs of erythema, redness, or warmth of that leg that has an infection. If it's a dry ulcer, we want to try to maintain that dry eschar. You don't want to get it, convert it into a wet ulcer. It needs, I usually do an inidine type dressing or a dry dressing, and offloading. If it's a wet ulcer, needs debridement to get rid of the wet, sloppy material. And then you need some sort of moisture balancing dressing. So if it's on the drier side, you can use something like Intracite or Inidine to balance that moisture. Something in the middle, you can use something that's something like Mepitol or something similar. And if it's more involved, you can use something like Aquasol if it's much more wet to dry things out. Again, there are a ton of different options for wound care products, and there's no one savior in all of these things. But to highlight, you need to assess your arterial perfusion as a priority, because your antibiotics aren't going to get there if your blood flow isn't good. You can do the best debridement and the best wound care in the world and the best offloading, but if you don't have adequate blood flow, this is not going to heal. And to that last point, offloading is very important so that any pressure that's on that very sensitive wound doesn't further make the wound any larger. So offloading in the end is a huge component of healing these ulcers. So how do you make a referral and when to make a referral? So if you have a patient that doesn't have symptoms where it's at high risk, you should get them assessed from an artery perspective, and they should be seen to get their risk factors modified to get them on the right medications and to prevent future issues. If they have claudication or pain in walking, they should get an artery assessment with an ultrasound and get a referral to be seen by a vascular specialist, again, to be able to do procedures to help them when they're walking, as well as to get their risk factors appropriately modified. This is the biggest category that our group is focusing on. So patients that have critical limb ischemia, so again, tissue loss, ulceration, or rest pain, they definitely need an artery ultrasound to assess their perfusion. They need to be seen urgently by a vascular specialist to be able to provide additional blood flow to get this to heal. And the final one, acute limb ischemia. Patients that were normal one day, and then all of a sudden, they can't feel their leg, they can't move their leg, and it's a rapid change, over minutes and over hours. These are patients that need to be sent to the emergency department. They need a CAT scan, and they need an operation that night. So going back to types of ulcer, that covers the arterial ulcers. There's a number of patients that have venous ulcers, and again, many of them have a component of all three here. But to review venous ulcers, we have to kind of understand what the vein system looks like. So vein systems can be divided into the deep and to the superficial system. So the deep systems where people get DVTs, we're talking about the femoral vein, the popliteal vein, iliac vein. These are the ones that we're more commonly known to. The other system is a superficial system, so the greater saphenous vein, the lesser saphenous vein, the veins that are next to the skin. So one component of veins not functioning properly is having insufficiency or reflux. So what that means is there should be valves in the vein that work in one direction, from the foot back up to the heart. And it works like an elevator. So every step of the way, it should lock to work in one direction back up to the heart. If patients have valves that don't work properly, so insufficiency, they get reflux of the blood flowing in the incorrect direction down into the foot and down into the leg. And because of that, they can have significant symptoms and eventually develop an ulceration because of it. So the risk factors for having venous disease are listed here. So it's older age, being on gravity long enough, female, pregnancy, because put pressure on the veins as well as the hormones during pregnancy, having a previous blood clot, trauma, obesity, and a family history. So this is the terminology we use when we're discussing amongst ourselves about how to talk about vein disease. So the clinical signs are, patients that can start off with the first level of having spider veins, telangiectasia, bigger varicose veins, which you're a bit more familiar with, that can eventually lead to swelling. And then after the swelling, the blood actually exits the veins and can start staining the skin. And eventually can actually thin the skin and kind of erode the skin that you can get a healed ulcer or an open ulcer. The reason why these can happen are because it can happen because of congenital reason. It can be often the way their veins were formed. That they can become they can have because of primary reason, And finally, secondaries are usually DVT. The anatomies, like we reviewed before, it's usually in the system or the deep system, or between the two, which is the perforators. And finally, the pathophysiology before that, it could be reflex, like we said, valvular dysfunction, obstruction, so DVTs or SVTs, so clots in the superficial system, or a combination of both. So how do we know what we're dealing with both anatomy and pathophysiology? We need an ultrasound assessment, because that'll give us an idea of what treatment types can happen. So what are the indications for treatment? It's a broad spectrum. It can start from cosmetic, symptom relief, prevention of complications, and the treatment of the complications. And we'll talk about the wounds shortly. So compression. So compression is needed for patients that have valvular dysfunction or that have obstructive function dysfunction, and different vein pathologies. The most important factor of compression is that you need to have adequate artery or blood flow to the foot before you compress your leg. So there's lots of different types of compression, compression, stockings, garments, Coban wrapping, Profor wrapping, different types of, Velcro wraps in order to assist with the lower extremity swelling and venous insufficiency, as well as obstruction. But regardless, if you're looking to compress a patient's lower limb, they need to have an artery assessment. If you go to compress a patient that doesn't have normal arteries, you can make those ulcers much worse, and it could lead to an amputation. So once again, before you're compressing a patient's lower leg, they need an artery assessment. So if they do not have palpable pulses, and palpable pulses are very difficult to even feel, even for a vascular surgeon in patients with a lot of lower leg swelling, because you can't feel a thing, they need an artery assessment to make sure it's safe to compress. So treatment options can include sclerotherapy, which are injections of a solution into the vein that can kill them off. So these are usually treatment options that we do for small isolated veins, and as well after we treated the large veins as an adjunct to kind of finish things off. So if you have superficial disease, you can treat it with compression stockings, which we talked about, although that's not kind of definitive, it doesn't solve the problem. Surgical stripping and endovenous options, which are a combination of either laser, radiofrequency, or glue. So surgical stripping is kind of the old school surgery. It's a surgical incision in the groin. You go to sleep, you actually pull out the whole vein, and there's multiple cuts below the leg. The challenge being it's an old school type of surgery. You have to go to sleep. So, a lot of our patients are at higher risk of an anesthetic. It's a more challenging recovery time. And generally it's a less successful surgery. This is the one that is covered by OHIP, but there's unfortunately long wait times to get this done because of the surgical backlog. Then there's endovenous options, which these are the ones that are the less invasive options. It's done in the clinic. It's done under local anesthetic and ultrasound guidance. And so patients get, just a percutaneous access. So it's kind of like putting a central line in to the vein. We put a laser fiber through and we heat up the vein. You don't feel a thing, and it shuts the vein down and can completely treat the vein system. Again, there's different types of endovenous options. And the most common and popular one is the EVLT or laser treatment. So if you're comparing the two treatments, the endovenous option is a much less invasive option with a faster recovery and is very good for treating venous disease, particularly the superficial disease with patients that have ulcerations, which we'll talk about shortly. So our guidelines are very clear that if you have superficial disease, the best evidence is for the endovenous options. So this is just an example of kind of patients with greater saphenous vein challenges that have had treatment with endovenous laser ablation, as well as the short saphenous kind of behind the legs, and these are kind of very quick turnaround. This is an area we want to focus on. So patients that have venous ulcerations. So these are ulcers that have been very challenging for patients to heal. We've seen patients that have had ulcerations in these areas managed for months and months and months and even years. They can be very, very painful, very wet, and have open and close and open and close and get chronically infected. And the way to treat these ulcerations, as we'll go through the algorithm, is first we need to be able to identify it. So you need to know if it's an artery ulceration, artery type ulceration, a venous type ulceration. And the way to do that is through an artery and vein or ultrasound assessment. Once you've diagnosed that it's a vein assessment, the best treatment for this is actually a laser treatment, because it can be done in a non-invasive way or less invasive way. And there's great evidence to show this is the quickest way to heal the ulcer as well as prevent future ulceration. And you can see that this is something that can heal over weeks, as opposed to the months and months that especially with these challenges. So this is my quick algorithm of how we manage venous ulcers. So if you're suspecting a venous ulceration, so again, in the medial aspect of the ankle, swelling, wet ulcer, you need to have an assessment of the vein with an ultrasound to see if there's valvular dysfunction and if there's any obstructions or any DVTs. You need to assess if there's any artery problems. So if they don't have any palpable pulses, which are very difficult in these patients, you need an artery ultrasound. Then you can know what you're working with and how to manage it. The next step is, again, you want to rule out any infection. All venous ulcers are generally wet ulcers. And so those are the ones that have a lot of serious drainage. So they generally do need to be debrided. And again, going into the moisture balancing dressing. These are the three I use. You can use any type of them, but you want to be able to control the moisture for this wound. And the final thing is compression. So being able to compress and decompress these arteries to allow them to heal. Our goal as vascular surgeons is to treat the vein that's underlying, that's causing these problems. And once again, we have a combination of endovenous options, so the laser, surgical stripping, as well as sclerotherapy in order to manage these and to get these to heal. So when to refer, if they have smaller veins or bigger veins, they can be treated for symptoms, for pain, heaviness, swelling, for cosmetic reasons. If they have swelling or skin changes, the goal is to prevent complications, because quickly they can become into ulcers. And that's something we want to prevent and heal. And so if you have the more advanced ulcerations, we want to treat these ulcers and prevent future ulceration. So what are our goals for limb preservation? And this is kind of our One Vascular Health initiatives, is we want to increase the access for these patients that have lower extremity wounds to get a vascular assessment. So we're trying to decrease the barrier for these patients to be able to be seen, so to get a referral. So there's always hesitancy in wasted time with primary care physicians. They're already busy as is to get to vascular surgeons. Often, a lot of vascular surgeons aren't seeing these types of patients, and that's why we set up these centers. Patients often have to travel quite long distances to get specialist care, or have to be seen in the hospital, which can have significant travel costs and parking costs. Like we said, there's often long wait times to see specialists, to get testing, and to get a management plan. Our goal is to empower healthcare professionals like yourself that are boots on the ground, managing these wounds, to get assistance where needed, to get assessments where needed, and form a joint management plan for these wounds. So the key here that we to summarize today is our goal is for early vascular testing and revascularization as quickly as possible to manage these wounds, and together to establish a wound care plan with a multidisciplinary approach. So our team at One Vascular Health, our goal is to provide comprehensive cardiac, vascular care, and diabetic care through the Community Healthcare Coalition. So that's ourselves as One Vascular, our cardiology colleagues as KMH, and our diabetic care colleagues with LMC to prevent loss of limbs in the lower extremity. So we work with a group of 20 vascular surgeons and a number of vascular specialists across Ontario. at a number of centers, which will show shortly, to be able to assess these patients, to provide the imaging and assessments as we were talking about, and work together to provide management plans for this high-risk population. So how do you get us and how do you provide care for your patients? This is our self-referral form. So once again, we want to provide and try to empower everybody that's working with us and that's on our call today. So you don't need to be a physician to provide the referral to us. We're looking to get our patients to be seen by our specialists in the easiest way possible. So if you work with an MP or you work with a physician that can provide a referral, that's great. And if you don't, that doesn't matter. We're happy to see these patients to be able to provide appropriate care. So this is our self-referral form. To be quick about it, you just need to provide the patient information, and if they're willing, your information of how to contact you and where to contact you, what you're referring for. So wounds, peripheral arterial disease, diabetic foot, lymphedema. If you can provide a history of what the challenges are and what kind of you've done so far, that's great. And we'll take care of the rest. So we'll organize the appropriate imaging. We'll make sure that these patients get seen on an expedited and a quick basis. They'll be assessed by one of our vascular specialists, get their appropriate imaging. We'll make a plan, keep you in communication with yourselves, as well as we loop together our specialist care. So if they're a high-risk diabetic patient, they'll be seen by our endocrinologist and our chiropodist in order to manage that, as well as if they're a high-risk cardiac patient, they'll be seen by our cardiologist to be able to manage this as well. So we have a number of locations kind of across Southern Ontario. They're all listed here. And you can send the referral and be able to triage it to our closest location. So thank you very much for everybody joining this evening. And thank you, Kathy and the NSWOCC group for allowing us to present today. And myself and my colleague, Ted Rapanos, will be happy to answer any of your questions.
Okay, and thank you very much, Dr. Elias. That was very informative, very interesting. I always learn a lot when I attend these webinars, and you did not disappoint. It was excellent. So we have quite a few questions that have come in. I'm going to start with the first one. What are your thoughts about using nitro patch to improve blood flow to the foot?
So I've seen that method, and I've actually used it myself for a number of patients. I think that's one component as an addition to be able to assist things. What it does is cause the blood vessels to dilate, and particularly the small blood vessels to assist to allow things to heal. I don't think you'll find a ton of evidence to support that, but the biggest thing is they need to have their big blood vessels working before you'll get their small blood vessels to be able to assist. So I think that's kind of one of many things in order to allow things to heal. But you better make sure that the taps are open up top before you try to add a nitro patch, because it's not going to really do much on its own. But I think it's an additional trick that can help with patients that have challenging wounds and have small vessel problems that can be assisted with. So I've definitely used it on some of my patients, but in and of itself, it's not moving the meter all by itself on that one.
Okay. Dr. Rapanos, do you have anything you'd like to add on to that?
No, I agree with Dr. Elias, 100% on what you just stated. Yeah.
Okay, perfect. The next question, this is quite interesting. It has to do with positioning. This person says, I perform ABI, TBI assessments at the bedside with a Doppler. If the client is not able to lay completely flat due to scoliosis, for example, how does it affect the results?
It's a great question. Generally trying to keep it at the same level, because that's what you're doing the blood pressure, so gravity will make a difference for things. If you're having a patient that's having that significant of an issue with assessment, I think they need an arterial ultrasound. Your ABI is a quick, great screen, and it's great for bedside. But I've seen a lot of false results with ABIs, and that's the biggest challenge with it. It's patient dependent, it's user dependent. It's a great quick screen, but if you have a patient that you think is that at risk of arterial disease or already has a wound, I think you're beyond an ABI at that point. You need a full artery assessment. And that's what I'm trying to highlight, because I've seen patients say their ABIs are 1 and they're definitely not 1, or say the ABIs are 0.1 and they're they have palpable pulses. So I have a little bit of a challenge with ABIs because there's a lot of inconsistencies with it, unfortunately.
Okay, thank you. I'm going to direct the next question to Dr. Rapanos. It says, I've seen many arterial ultrasound reports be quite vague, only stating APBI is normal. Is there anything in particular that can be written on the requisition to get more a clearer vascular picture?
So one of the reasons I started One Vascular Imaging is I've been in practice for 15 years. And in the first 5 years, I would get these ultrasound reports and they would state, normal, or I had a bologna sandwich for lunch, CT recommendation or MRI recommendation. And I thought that was a waste of taxpayers' money and patients' time. I couldn't interpret those as a vascular surgeon. I would look at those and I'd be like, well, goodness, what am I going to do with this? So, and the problem with this is a lot of the labs out there are multimodality. They do breast assessments, they do general ultrasound, X-ray, and vascular. So they don't have the expertise, and they're reported by radiologists. What we do is we almost exclusively, everyone that reports to vascular surgeon gives you a vascular surgical opinion. In that, you want to know what the waveforms are, you want to know what the ABIs are, the TBIs. There's a lot of information, like Dr. Elias presented, where a proper ultrasound can avoid doing further imaging with contrast to the patient and cost to the healthcare system and cluttering the hospital with unnecessary tests. So I agree with you that a lot of these ultrasounds from these multimodality non-vascular labs, yeah, they could be a waste of time. Dr. Elias, what's your thoughts on this?
Yep, I totally agree. And with that, it doesn't, it's just stating, a lot of these results are just stating numbers and they're stating, waveforms. But what really matters is an interpretation and a recommendation. And that's what we can do as vascular surgeons. We can provide insight into, how much flow that really is. Is that being effective? Is there blockage? And then you're providing the opinion with that, and that's what comes with our reports. And I think that's very key to help with the decision making, because again, you don't just need a number or something that's not very helpful for making your decisions. If you're asking, do I have enough blood flow for compression? That's something that we'll be able to answer. Do you have enough blood flow for healing? Also something that we'll be able to answer through our arterial assessments.
Yeah.
Okay, thank you. Going back to Dr. Elias, this statement, we always do TBIs in a diabetic. Am I correct in assuming that the palpable DP pulse is not sufficient for conservative sharp debridement then? We stay above bleeding tissue.
So we always do both ankle brachial indices and toe brachial indices in all our assessments. For that reason, because you can have a false elevated or calcific vessel for an ankle brachial index. So it gives you the toe brachial index and the toe pressures give you a more sense of microvascular disease and compromise. If you do have palpable pulses, and that's a true palpable pulse, you are pretty confident to do sharp debridement. The reason why I'm a little bit skeptical is, again, even as a vascular surgeon, and I train a lot of vascular residents and trainees, is they're often feeling their own pulse when they're checking for a vascular assessment and pulses in the lower leg. And that's why, you do an assessment with a CT or an ultrasound, and they really have a lot of blockages, and they were told they had palpable pulses. That's not very true. Or if they have a lot of swelling in the lower extremities, it's very difficult to assess too. But if you truly have very reliable palpable pulses, then yes, you should have adequate flow to do a sharp debridement. I just, again, get very skeptical and seen a lot of mistakes happen because it's not a very sensitive test necessarily, and even vascular surgeons mix that up all the time. It's feeling your own pulse, not the patient's pulse.
Okay. The next question is around pain management. So could you describe what type of pain you're typically seeing in patients with venous ulcers versus patients with arterial ulcers? And what would you recommend for effective pain management?
That's a great question. So the spectrum for pain presentation for these patients is really variable, and that depends on the level of their neuropathy. So if we take artery patients, arterial ulcerations, you have some that, they have pain all the time, particularly on the forefoot, and that's more indicative of the arterial presentation. And they have pain with their leg elevated because of lack of blood flow. And so that's why they tend to, hang their foot over the bed or sit in a sofa, or sleep in a sofa chair to have them leaning over to provide, additional blood flow to allow that to get the pain less. Whereas venous ulcers are typically more that kind of medial malleoli area where there's a significant amount of pain. But it all depends on their level of neuropathy. So I've had patients with, half their foot off and, not having any pain or symptoms at all. So it is very variable. In terms of management of it, it can be quite challenging because they can get into maybe a bit of a chronic pain circle. And so I think you do have to work up the ladder in terms of pain management. So starting with your opioids, but often adding sometimes your anti-inflammatories. We have a few local topical kind of items that can work as well. But again, finding the source of the problem is a huge factor. So, arterial ulcers, probably one of the most painful presentations there can be. And providing additional blood flow can really provide significant relief quite quickly. So if you're having a really painful ulcer, that's concerning that your arterial flow is very compromised.
Okay. And Dr. Rapanos, do you have anything else to add to that?
No, I agree with Dr. Elias. I mean, you can treat them with anything, but the reality is they need an intervention, and that's the fastest way to get them out of that. Arterial, a lot easier than venous, I find, because they're ischemic. You treat the ischemic symptoms and almost instantaneously the pain has gotten a lot better. The venous ones are a lot more difficult because even though, let's say you've got reflux and you do an endovenous procedure or you strip the vein, there are perforators that will keep things alive in Gator's area down around the ankles. So those ulcers may not heal as fast as you'd like. So you're going to continue to treat them, with all the wound products we discussed. The pain will continue. Those are a little bit harder and trickier to treat from a pain perspective, I'd say.
Okay, thank you. The next question, is there anything that can be done for a diagnosis of systemic vasculitis? The patient states she has been given only amputation as the plan.
It's a quick question. So vasculitis is probably lower down of what causes peripheral arterial disease in lower limb ulcerations. It can be a lot more tricky to manage. It depends on how bad their lower extremity really has become and their vessels really become. There is medical treatment for vasculitis, whether that's steroid treatment or biologics to kind of reduce things. But you can definitely perform bypasses and angioplasties on these patients. The challenge with these is you have to treat kind of the underlying disease, and depending on how far and how late the diagnosis of vasculitis really is, that can be quite challenging to treat for sure. So those are a little bit more of unique case circumstances, and probably not what the majority of your lower limb ulcers may be. It depends on kind of the course of when this vasculitis was identified and how far gone the leg really is. But I'd say those are a little bit more unique cases that really do need a vascular specialist assessment.
Okay, thank you. I'll put this question out and you can decide between the two of you who answers. When patients have claudification, such as diabetic patients, are ABI results safe to determine whether to use compression?
Sorry, the question was when patients have claudication?
Yeah. Like diabetic patients, are ABI results safe to determine whether to use compression?
So I think you have to look at the entire report. You're going to look at the ABIs, you can look at the waveforms, you can look at the TBIs. I would say if you're just looking at the ABIs, then no, I would not treat Dr. Elias.
Yeah, I would agree because, like we said, if you are diabetic, you're going to be known to have a falsely elevated ABI, and so it may say 0.9, but truthfully, you have a lot of blockages in your arteries, and that's not really the amount of perfusion you're getting. So you need to look at your toe pressures. So an ABI alone for a diabetic patient with claudication, and claudication also would mean that they have some sort of blockage. So that would, I'd be hesitant to compress with an ABI alone. They need a full arterial assessment, and that's what a vascular specialist can help assist you to prescribe what type of compression, if any, they can have. We're often treating the artery disease first, with an angioplasty and stent, and then compressing the patient. So you make sure you're safe and make sure you're clear.
Okay. And what are your thoughts on the use of a tensor bandage to reduce edema in lower legs due to CHF and active lower leg wound in patients with unknown arterial status? Is this safe?
I think it's very unsafe, unfortunately. The two issues is unknown status is definitely the case, because we've seen both Ted and I have seen, tensors or compressions go on limbs that are not assessed from an arterial perspective, and they've led to amputations. That's one component. And the other challenge is tensor bandages can be dangerous in themselves, because they're not put on generally graduated, and so it can provide a lot of pressure in one area and less pressure in the other, and push fluid back down the leg, not up the leg. The tensors in themselves have their own challenges. So I think both those things can be very dangerous for high-risk patients.
I agree with Dr. Elias. I mean, I know of one case of one colleague that was sued successfully. He did an amputation on a patient, and his trainee put the tensor on extremely tight, and it was on for 48 hours, and then the patient required a revision. You don't even know what tension you're putting that tensor bandage. Myself, I'm a weak man. It would be very light compared to Dr. Elias. So I think it's very unsafe.
Okay. And what types of offloading would you recommend for arterial wounds? Is there anything specific?
That's a great question. The offloading I would recommend is anything that the patient will wear. I think it's all about compliance. So I've seen, makeshift ones. I've seen, Darko boots, anything you can really get, just even just a regular diabetic offloading shoe that you can get. It's basically all about compliance, because it's not very helpful to have the fanciest offloading shoe sitting on the shelf, or they're rolling in with it, in hand. That's not providing the assistance that they need. So it's whatever the patients can wear, and sometimes it's whatever the patients can afford, unfortunately, that I recommend. That's the most important thing.
Okay. And we have time for one last question. What is your recommendation to manage large ruptured blisters due to fluid overload in a patient with CHF with unknown lower leg vascular status presenting with cellulitis? Should it be deroofed in order to get a clean wound base to treat with an antimicrobial dressing, or should something else be done?
It's a good question. So I think you kind of work down the algorithm. So the source of the problem, which is their CHF. So you definitely need to be seen by a specialist to be able to get them on, get their CHF under control, get them on Lasix or getting their cardiac status managed. That's the source of the problem. Get an adequate arterial assessment to be able to compress them. I think the compression itself is only really temporary. Compressing patients with CHF is a temporary fix to allow things to heal, but you need to fix the CHF to get them really involved. If it's a massive blister with a lot of volume, it's not unreasonable to drain it, because that's going to be very difficult to compress in order to provide adequate compression afterwards, and to provide some sort of protective layer. But again, I think you have to fix the underlying problem. Otherwise, you'll have challenges with whatever wound care product you'll provide.
Okay, thank you. And Dr. Rapanos, there's a comment for you. Have you ever thought of expanding your vascular lab to Alberta? We need you here. That was the comment.
So we've been very fortunate in expanding across Ontario. We're the largest provider right now for vascular surgical services outside the hospital. We've met with the Minister of Health and the Minister. There's been a lot of support. Like Dr. Elias said, we're part of a coalition. So what we're doing is we're decanting a lot of the stuff that doesn't need to go to the hospital. The hospitals are overwhelmed. And I don't think it's just an Ontario problem. I think it's an Alberta problem. I think it's a Canadian problem. So we'd love to. I don't know if we're there yet. We're still in the middle of working through Ontario, but we'll put that on our radar, Dr. Elias, as our next visit.
Okay, and I think the general responses here, people are saying thank you for making quality vascular care accessible for their clients. So they're very happy about that. We've come up to the hour, and I would like to take the opportunity to thank both of you for being a part of our educational webinar this evening. We couldn't get through every single question, but if you do have a question, you can email office@NSWOCC.ca, and we'll definitely see if we can get Dr. Elias and Dr. Rapanos to answer it. Thank you to everyone for being a part of this evening, and I wish all of you a happy Easter or whatever celebration you're observing over the weekend. So have a great weekend, everybody, and thank you.